Namaskar. Further, it's today, 28 December 2024. Myself, Dr. Vipul Gurjar. I am the head and department of the surgery and the professor of the surgery in Sumandip University, Vadodara. Today, I am giving the explanation about the basic thing and what is the practical approach of obstructive defecation syndrome. This topic is very important to about who is doing the anorectal surgery because we are dealing normally with the piles and fissure and fistula everything, but we are not considering the cause of this piles fissure and the fistula. So today, the most common problem of our new life modification is the constipation. And among that, one part is the obstructive defecation syndrome. Name is ODS. Now, what is ODS? Okay. First, the we are going with the some theory part, then we'll go with the investigation and practical approach how to tackle and how to diagnose about the obstructive defecation syndrome. Okay, now the why the patient is coming to you, like the pious patient is coming, there are the two symptoms. One is symptoms bleeding and second is a symptom is the constipation. Okay, this constipation can be divided in two ways. One is the physiological constipation, or second is the surgical constipation. This is a two terminology I understand myself. Or uh, by theory, you can divide this constipation in a two way. One is the anatomical and second is the low transient constipation, that is known as a pathophysiological constipation. That means patient is not desired to evacuate because of that delaying reflexes of colonic transient or colonic reflex, gastrocolic reflex are changed because of the life modification. Everything. There are multiple reasons behind it. So that is patient is no desire for evacuation. Means patient आएगा, पेशेंट का टाइम निकल जाएगा तो फिर उसको स्टूल पास होने की कोई अर्जी नहीं आएगी. दैट इज द नोन इज अ पैथोफिजियोलॉजिकल कॉन्स्टिपेशन. Now, as a surgeon, we can give them multiple treatment, like a life of this type of constipation. We can give the some medical treatment. But as a surgeon, we are interested about the surgical part, that is known as a surgical constipation, or it is known as the obstructive defecation syndrome. That means what? Patient is feeling about to evacuate, but he is not able to evacuate. That means patient may feel something inside the rectum. He feels, but when he pass, but he is not able to evacuate proper. That is known as the obstructive defecation syndrome. Okay. Now, if you want to know about the slow colonic transient time, then we will discuss first it. Slow colonic transient time, there are the investigation in which radiopaque pills are given, then the multiple x-rays are taking to know about the slow transient time. Second thing, the gastrophysician friends are taking the urease test. It is also gives the some idea about the slow colonic transient time. This slow colonic transient time can be treated with the multiple drugs as well as life modification, dietary habit. While in a surgical constipation, what happens? Because of the long constipation and because of the forceful habit of evacuation, there will be a muscle disparity. The rectum and anal canal is surrounded with the multiple musculature. This muscle has a the stress because of the mechanical force, and this muscle becomes a with the contractility, like means is a physiologically as well as a anatomically there will be change in this musculature what God has gifted us. Because of this disparity musculature, now the support of rectum or the anal canal becomes a means imbalance. Now, if the rectum is a full rectum, that is a full rectal wall is coming out from anal, there is a known as a full thickness rectal prolapse, which is not considered as a obstructive defecation syndrome. That means this full thickness of rectum may not have a problem of constipation. This type of patient may be some genetic disorder or the embryological problem causing the musculature weakness, and that cause of full thickness factor. We are not considering this as a obstructive defecation syndrome. The obstructive defecation syndrome in a practical to understand, there are lots of parts theoretical, but practically to understand I am explaining in easy trying to explaining in easy way that once when you pass a stool, try to pass a stool, internal rectal mucosa becomes so much lengthened or redundant. So during the squeezing position, stool when passing through the rectal wall, because of this redundant mucosa, this all the internal mucosa will progress first, and that cause a narrowing of anal canal lumen. And because of this narrowing, this stool ball will not go outside easily. And that's why the patient may feel difficulty in evacuation. This is known as obstructive defecation syndrome. Now, there are the different type of obstructive defecation that easy to understand. That is, first is a rectocele. That means rectal wall is prolapsing inside. Second is the mucosal intussusception. That means the surrounding whole rectal mucosa goes inside the rectum. That is a rectal wall intussusception. And the rectocele, this mostly presented in a female patient. If you judge in my clinical practice, whenever I got the old lady or the female patient, I definitely ask about the gynecological procedure. This most of ladies are develop these symptoms after the hysterectomy, because this was bladder, uterine, and the rectum are surrounded with the one single musculature pelvic floor, and because of this support imbalance, removal of this uterus, there will be a imbalance of these three viscera, and because of that the prolapse will occur. Normally these prolapse are the tricompartment prolapse also in a female patient. What is tricompartment prolapse? If uterus is also going back down to the vagina, if bladder having a same urinary problem, like a patient is having some difficulty in micturition, and third is the constipation, this is known as the tricompartment prolapse. Because of the laxity of the whole pelvic floor, this is also considered as a obstructive defecation syndrome. This obstructive defecation syndrome, one is the circular rectal mucosal intussusception, tricompartment prolapse, and third is the rectocele, in which anterior wall of rectum becomes a like a diverticuli. It becomes a form a diverticular pathology. So the stool, when it is coming, it goes anteriorly inside the pouch of rectocele, and he is or she is not able to evacuate properly. Okay, so this is somewhat a basic idea of obstructive defecation syndrome. First, because of that obstruction, and second is the widening pocket of rectum which collect the stool, and this collected stool is not coming out. Third is the because of the laxity of pelvic floor, the whole organs becomes a prolapse. Okay, so this is a easy way to understand about the obstructive defecation syndrome. There will be a sigmoid prolapse, enterocele, there will be everything, but how to understand the obstructive defecation is this is a simple thing. Now, because of this obstruction, patient will strain, more strain, and that's why he or she will develop a fissure also. So the presentation is a fissure because it is painful, and the patient having a constipation definitely. But what is the cause? Because of this rectocele, because he or she is not able to evacuate. Now, this is a fissure cause. Second thing, the piles. Once a patient, because of straining, this is because of the whole day or whole time of evacuation, he will strain, and this is a cause of fragmentation of pile cushion connective tissue, and then the piles becomes a prolapse out, and later on it becomes a bleeding piles. So what is the presentation? Is a bleeding piles. What is that bleeding piles? It is because of this strainous process. What is why the strainous process? Because of this obstructive defecation syndrome. That means the piles fissure are the symptoms of obstructive defecation syndrome or the rectal prolapse. It is not a primary disease, and we are dealing with only the primary no, secondary disease. We are not dealing with the primary disease in a normal treatment. Okay, so we have to think of this also. Now, the sometimes patient, how to diagnose? Now the first, how to diagnose this type of obstructive defecation syndrome? First thing, the symptoms. There are the first, if you are interested in obstructive defecation syndrome, then go and know about a Longo scoring system. Dr. Longo, who is the inventor of MIPH as well as STAR procedure, he has given the Longo scoring system. In that, he suggested the difficulty in evacuation, manual digitalization, evacuation, time consuming for the evacuation, frequency to go back to evacuate, the time sparing in the bathroom, toilet, and life disturbance. He has given a 24 marking. If it is more than 9, then it is abnormal. So, according to this Klongo scoring system, the symptoms can be isolated for the obstructive defecation syndrome. Okay, this is the symptoms. Second thing, patient, how the patient is coming? Patient will say, I am not able to evacuate properly. I have a urge, but I am not able to evacuate. Sometimes the patient may have symptoms of bleeding and pain, dragging pain or heaviness inside the rectum, because of the strenuous process. Third thing, if old age female patient may have a simultaneous vaginal prolapse or the urinary problem, or incontinence of urine because of this laxity. The patient may have a perianal and a buttock pain because of the spasticity of puborectalis and external muscle also. This is also considered as a ODS. Now, another symptoms, patient may have a bleeding PR. Now, on examination, you may have found, on first you will look externally. Okay, this obstructive defecation patient always may have some associated laxity of the pelvic floor. Because of this laxity of pelvic floor, the anus and all the buttock prominence becomes a straight line. That means the pelvic floor, anal is coming outside the pelvic, this buttock line. So it will be a flat position of anal region. That is, anal will be in the middle and buttock prominence will be on the same line. That is a flat and no buttock line. This is the some gives the clues about this obstructive, that is a pelvic floor descent. Okay. If you do the PR, if there is a no fissure, you will feel a very lax the sphincter, as well as when you move the finger inside the rectum anal canal, you will be feel a freely lax mucosa. Then in a female, if you fingering anteriorly, you will find a bulging in the vagina, very lax. That is known as a rectocele. This may be a mild or to moderate one. On proctoscopy examination, you will find piles may or may not, but in a rectal mucosa, this obstructive defecation, you will find a pinkish color mucosa is bulging inside the proctoscope. This is one of the most important diagnostic value. The bulging pinkish color, not the piles, pinkish color, the mucosa is trying to bulge inside the proctoscope. As well as you may have a ulcer in the posterior wall of the rectum. What is that known as a SRUS, solitary rectal ulcer? That is also a diagnostic value of obstructive defecation syndrome. What is why this ulcer? Because of this strain, because this is a rubbing of mucosa intussusception itself, this causes ulceration. That is, it is not a malignant, but it is a chronicity of this strenuous process. It is also a salivary rectal ulcer, and many times your endoscopy friend will give this terminology SRUS. This is a definitely indication of the obstructive defecation of the surgery, and this is indication of the surgery. So, patient may give, sir, I need to evacuate with the finger. That is also a indication of obstructive defecation syndrome. Now, is there any investigation? Yes, there are investigation which confirm our the diagnosis about obstructive defecation syndrome. One is the most important is your clinical, and after that is dynamic MRI, that is the MRI difficography, in which the patient is supine position, lateral position. They inject the jelly inside, and then patient is asked about to evacuate. And during this phase, they'll take a MRI and they will see the whole process. That means how the rectum wall is working, how the sphincter is relaxing. According to their criteria, the PC line, pivorectalis sacral coccygeal line, they draw and they will give the clues about the rectification or rectocele, like etc. But according to me, it is not 100% confirmatory. Why? What is my problem? Why I am thinking this MRI difficulty may or may not help me, but they may give the clues, or it is important for the documentation. But because see, once, like, if anybody ask me to evacuate anytime, is it possible? No, I am not comfortable to evacuate anywhere except my bathroom. Even I have a two bathroom, I am using one bathroom only. If I am going in a second bathroom, I am not satisfied. Okay. Second thing, time. MRI difficography, this we have a urge in the morning. So MRI difficography is is not possible. Third thing, the position, the squatting is the ideal position for evacuation. While in MRI, because of this stable supine position, this it is not possible at all. Now, the force of evacuation, let's say natural force when there is a stool inside, and when the jelly is putting inside, the force will be a different one. So the MRI difficography may not be 100% effective. Okay, that may give the clue, and you consider as a documentation. The most important is your the symptoms. Second is the evidence based, the MRI difficography. But I believe personally is the swab test. The examination under anesthesia is the best thing. Before that, one another investigation is the anal anometry. This anal anometry again gives the clues about the sphincter, the anatomical pathophysiological changes during the defecation because of this tightness, relaxation. They may give some clues. Okay, so anal anometry is one of the good investigation about to know about the musculature, which are the one cause of obstructive defecation syndrome. Okay. Now, what is I believe is the swab test under anesthesia and under anesthesia. What is swab test? After the giving the anesthesia, the patient is given the lithotomy position. I applied the circular anal device of the MIPH. Then I'll take a swab, like make a gauze like a stool ball, lubricate with the jelly, take a swab holder, then I push inside the rectum and then pull back. If your gauze ball of a stool is obstructing because of this mucosa, it is maybe the obstructive defecation syndrome. Second thing, if the mucosa is coming up to the outer border of the CAD, that means this is a large into susception, and this patient required some surgical excision of this excess mucosa. So this is known as a swab test. Uh, Now, these are investigation, basic investigation. There are lots of another investigation, but I am not going. Even a sonography, perianal sonography, transanal sonography is there. But many radiologist friends are not aware and not expert about this transanal sonography, and so we are not doing. We are believing only about the MRI difficography and anal anometry. Now, how to treat? Further question, how to treat with the this obstructive defecation syndrome? If a young female patient is coming to you, then I will, if there is a definitely a MRI difficography suggest you have mild to moderate rectocele, I will not go for the any intervention further, surgical intervention. If patient is doesn't have any evidence of rectocele or intussusception, then also I will not go for the directly for the surgical intervention. This type of patient, or before going the surgical intervention, I would like to go this patient go for the biofeedback treatment. Give the trial about the biofeedback treatment. What is the biofeedback treatment? It gives train the perianal and the rectal muscle to evacuate. Because of this spasticity or the contractility, evacuation problem may be a disturbed. So biofeedback treatment is the in that they measure the contractility while the process of defecation, and according to that their physiotherapy friend may advise the relaxation as well as the contraction for the evacuation problem. According to need, we should give at least 2 to 3 biofeedback trial before going the surgical intervention. If it is fail, then we can go for the surgical intervention. Now, what is the surgery? Is the fixation of mucosa in situ. Okay, so what are that? Now the two surgery is available, or you can see is three surgery is available. First surgery, the Dr. Longo has advocated a star procedure in which the excessive internal mucosal prolapse is excised anteriorly with one stapler and the posteriorly with the second stapler. So the evacuation problem will improve. Star itself, on a long term, there are many papers are available for using of star or the late result of the star. After 3 to 4 years of star surgery, the satisfaction ratio is decreasing. But this is the only available treatment for the ODS. So that's why we have to explain the patient that the satisfactory ratio may decrease later on. So biofeedback later on, you have to follow that thing. One is the star procedure. Second thing is the pelvic floor descent. Now, before that, I would advise Dr. Roy Patankar sir of Mumbai. He is a very well-known laparoscopic surgeon and GI surgeon. He has published his obstructive defecation syndrome with LVR, ventral mass rectopexy, and he has published about the obstructive defecation improvement, but I am not aware in detail, and I am not doing this ventral mass rectopexy. But he said there will be a improvement of the obstructive defecation syndrome in compared to star procedure. But my choice at present is the star procedure only. Whenever there is an internal rectal mucosal prolapse. Okay, first thing. Now, when the patient having a tri-compartment prolapse, then what to do? Tri-compartment. Then Dr. Longo himself suggested a POP surgery. What is POP? Pelvic organ prolapse suspension surgery. And second, SIRS surgery, SIRS. That is a rectal suspension surgery. In that, the Douglas pouch or the pre-uterine pouch is fixed with the 30 by 30 sling of mesh pre-peritoneally and pull. So the all the symptom, all the pelvic floors come up. If the cystocele and vaginal prolapse is more, pops. If rectal prolapse is more, then the posterior anterior rectal wall is fixed with the 30 by 30 1-inch sling pre-peritoneally, laparoscopically, and pull the pelvic floor. They may improve the rectal prolapse as well as the pelvic floor in situ. If after doing this, if there is a redundant internal mucosa, you can add a star procedure that is known as a POPS star or SIRS star SOS. Okay. Another treatment is available by the Dr. Chiute sir is a transanal rectopexy. In this condition, posterior wall through and through posterior wall of the rectum, there are the fixation of the posterior rectal wall with the presacral fascia. In this way, there is a straightening of the posterior rectal wall. I have done this surgery 10 to 12 for obstructive defecation, but my satisfaction ratio is not good for particularly in this. So my a particular what I am experienced about the improvement in obstructive defecation is the star itself. Whenever there is an internal rectal mucosal intussusception or rectal prolapse or the rectocele. Second, if there is a tri-compartment prolapse, then I would go for the POPs if utrovesical symptoms are more prominent, or I will go over the SIRS if rectal wall prolapse is symptomatic more. Nowadays, I am advocating one more technique is the anterior star. In that, there will be a less posterior wall prolapse, only moderate rectocele. Then I'll go with the only anterior half of the star, not doing the posterior star. In this way, my philosophy is there that the anterior rectal wall are more lax and they are unsupported, while the posterior wall are the supported by the sacrum. So the redundancy is more common with the anterior wall. That's why I am cutting the anterior wall. As well as for the defecation process, the posterior wall is very important for the sliding over the sacrum, and that's why the ventral mesh rectopexy are recommended. And because of this anterior star, I am getting the very good result in maximum patient, because this maximum patient are mild to moderate one. These are the female patient. So I am not recommending, I am doing the anterior star. It's your choice. It's not published now, but I am getting my patient with a very good result. Okay. So now the patient sometimes on a PILES patient, we are doing the swab test and there will be definitely a mucosal prolapse. So should we go for the star procedure without obstructive defecation? See, the star procedure is the excision of rectal mucosa, excessive rectal mucosa. So doing of piles resection of excessive mucosa in a piles patient, star procedure has a no contraindication, because this patient may have a mild ODS symptoms but more prominency of piles prolapse. So you can do the star procedure whenever there is a large mucosal prolapse with piles, and you are not doing the MRI difficography. There is no harm. because MRI diffusorography is not a gold standard. I have given the explanation in previous part that MRI diffusorography why is not that much a gold standard. So according to your experience, you can do the STAR procedure also. There are definitely another procedure is also available for the obstructive defecation syndrome, but practically what I am doing, that what I am explaining in this video. So that's all. Thanking you. Please, I am expecting more questions regarding this, and I am very happy to give their answer. Thank you. Thank you very much.